Thank you, Dr. Escorn. So we just had lunch, and it's been over an hour. So basically, none of us have gastroparesis. It should be coming out of your stomach by now. Parasympathetic kick in. It's time for a nap, right? 20 more minutes, that's all I'm asking for. So today's topic is going to be management of cirrhosis. I'm going to talk a little bit about etiology and on management from both GI and primary care perspective. So as you know, cirrhosis comes from Greek. It's cirrhos, meaning yellowing. Although in a lot of transplant centers, when the bilirubin get up to 40, 50, people are more green than yellow. But we're going to stick with this for now. So basically, cirrhosis is a replacement of the normal liver tissue with scarring from chronic inflammation over many years. This process takes many years. It's not something that happened overnight, over a month or two. And fibrosis is one of the most common terms that we use in GI. It just stands for scarring. And when the liver is completely replaced by scar, that's cirrhosis. And as you know, there are a lot of different symptoms, signs, manifestation of cirrhosis. Jaundice being the most common one, that's why, cirrhosis, yellowing. And you also have varices, esophageal, gastric, ascites, hepatic encephalopathy, which can be very subclinical in a lot of patients and might not recognize very apparently. And of course, you have other edema, some other changes, spider angiomas, and sexual characteristic change, gynecomastia, and a lot of times spironolactone, which is one of the diuretics that we use to treat ascites, can also enhance that effect. The most common cause of cirrhosis in the US is hepatitis C and alcohol. And chronic hepatitis, hepatitis B and C. Hep B, not so much in this country compared to hepatitis C because we don't have a lot of vertical transmission here in this country due to vaccination of the newborns and also HBIG, which is Hep B IVIGs. And like Dr. Escorn said, Hep C is the #1 reason for liver transplant right now, but over time with all the new medication coming out, it's going to be replaced by something else that I will talk about in just a little bit. Alcoholic liver disease, as you know, is also very common. And when we talk about alcohol in these patients, I remember vaguely when I was a medical student, I spent an hour talking to the patient, so proud, got all the history coming out, talked to the attending. 5 seconds into the conversation, attending asked, so how much alcohol does he actually drink? I said, well, yeah, he said he drank about 1 drink a day. And the guy, when he drank, is a beer mug, which is about this big, of whiskey. And so my attending at that time, my preceptor gave me a really good advice. When you ask how much people are drinking, ask what kind that they're drinking, how big is that glass, not just how many drinks do you drink in a day, okay? And as Dr. Escorn said, fatty liver is going to be the #1 reason for liver transplant within the next decade or so. And it's been rapidly increasing in the US due to increasing morbid obesity. And like some of the first lecture we were talking about denial is also a big issue, where people get offended when you use the word obese, overweight, or some of them morbidly obese. Recently, one of my partners has a patient refused to go back and see her because she used the term morbidly obese. And the patient's BMI is only 59. And she was very offended when that term was used. So this is one of the hospitals that I was trained at. And sadly to say that they had to put this sign in after one very unfortunate incident where the patient obviously is weighed more than 500 pounds. Went into a GI clinic for foul smell diarrhea and had an episode in the clinic, sat down, broke the toilet, and flooded the entire department. This did not happen here, it happened in Minnesota. And obviously they had to shut down the whole entire floor, the department for that. And of course, this is actually an older hospital. So the floor, the water actually creeped down onto the floor, and underneath was dermatology clinic, and they had to get shut down too. I don't like them too much, so it's okay. Some of the less commonly cause of cirrhosis that we actually do a workup about, because some of these actually reversible. Hemochromatosis, autoimmune hepatitis, we all heard about PBC and PSC. PSC is more associated with inflammatory bowel disease like Crohn's or ulcerative colitis. We always work out for Wilson disease. It's pretty rare, but it's there. Alpha-1 antitrypsin, polycystic liver disease, which in association with polycystic kidney disease as well. Cardiac cirrhosis actually is not uncommon. So patients have severe heart failure over many years with the backup pressure from not control heart failure. You can have cardiac cirrhosis from this as well. And chronic veno-occlusive disease, basically chronic obstruction from the venous system inside the liver, and of course medication, methotrexate, INH being the top two. So what are the complications? Cirrhosis costs about 50,000 deaths per year. This is not including the 20,000 from liver cancer. That's addition. And some of the complications, the major one I listed here, vessel bleed, which we see a lot, ascites, spontaneous bacterial peritonitis, hepatocellular carcinoma, hepatorenal syndrome, hepatopulmonary syndrome, and also it should be listed as well, portopulmonary syndrome, and of course hepatic encephalopathy. So GI bleed, you know, from varices specifically for this talk. When I was a first-year fellow, when I see this, this typically the first thought to come to my mind is, am I going to pee my pants anytime soon or not? But now when I see this, it's like, sweet, this guy still has good blood pressure. We still have some time to do something. But mortality rate for varices is very high. And when I say mortality rate, I'm talking about 30-day mortality. 20 years ago, it was 30%. Despite all the advance in medical therapy that we have now, it's only improved up to 15, 20%. It's not that much. So when people start having variceal bleed as a complication of cirrhosis, they tend to do very poorly. Initial management is the key is resuscitation, IV fluid, blood transfusion, and reversal of coagulopathy, because most of the patient, obviously the liver make clotting factors, so they cannot clot well, and antibiotics to prevent further complication with liver decompensation. So one key with the blood transfusion, when someone is in hemorrhagic shock, this is not just liver cirrhosis alone, but keep in mind that when someone is in hemorrhagic shock, when you give them just packed red blood cell, they don't have any clotting factors in there. So the more you give packed red blood cell, that's being replaced by somebody else's blood, and they don't have clotting factors, you actually will create coagulopathy in the patient without cirrhosis even. So keep that in mind. That's one of the main reasons why in someone with hemorrhagic shock, you give FFP along with packed red blood cell. And of course, you know, this is where we come in, endoscopic therapy, band ligation, injecting with sclerosing agent, which we don't use much anymore. How many people here know what a Minnesota tube is? Okay, a Minnesota tube, when you actually Google it, this is just, a few years ago I gave a talk on GI bleed. So when you Google up Minnesota tube, this is what come up. I live in Minnesota for 22 years, and I do this almost every year. Okay, it's really fun, you know, just go out, instead of water slide, but you can't really have water slide when it's -40 outside. So you use the snow instead. It's really fun. But the Minnesota tube that I'm talking about is the Blakemore tube. So basically when you're bleeding, cannot be controlled with endoscopy or injecting agent to clot up the blood vessel. You put a tube through the nose. Obviously the patient, most of the time by this time they're already intubated. They pass the tube all the way in, inflate. They have two balloons. One is esophagus, one in the esophagus, one is in the stomach. You basically tamponade the blood vessel. This is a very temporary measure that just only used so you can go to the next step, which is a TIPS. So Blakemore is a name that's been used since 1950s, but in the 90s, the tube has been modified more to include another gastric suction contents where you can actually start suctioning up the contents from the stomach. And you can tell whether the patient's still actively bleeding or not, okay? So the TIPS is actually usually the next step if the bleeding is uncontrolled because, again, the Minnesota tube is very temporary measure. You cannot keep it there. Usually you have to remove it after 6 hours. because the chance of perforation from the esophagus is really high from pressure necrosis. And TIPS is, as you know, transjugular intrahepatic portal or systemic shunt, and bypassing the liver completely, really. Basically, it's somewhat barbaric when you actually watch interventional radiology do it. Go through the IG vein, the jugular vein, go all the way down to vena cava, get into the hepatic vein, and puncture blindly through and get to the portal system and put a stent in there, basically bypassing the liver. And two main risks that people can die after TIPS is decompensated liver disease, which, I mean, the patient's bleeding to begin with. So that's not the main concern. But heart failure, people can die instantly from overflow because they usually have a slow blood return to the heart. And now you bypassing the liver completely, you're going to have a big rush of blood coming back to your heart. And you can have cardiac overload from that. Hepatic encephalopathy is another, I mean, I'm talking about severe hepatic encephalopathy is another contraindication for a TIPS. But in terms of bleeding, you know, I mean, either you're going to let them bleed to death or you're going to suffer the risk of hepatic encephalopathy. So we don't want to wait until a patient's bleeding. So most of us, when a patient with cirrhosis, when we see them in the office, we always have to start thinking about prophylaxis. The way to screen for varices, obviously, endoscopy, and the interval is anywhere from 1 to 2 years, and all these I got from AOSOD guideline. And so it's surveillance, when you find varices, what are you going to do about it? So there are two ways of basically preventing bleeding is using non-selective selective beta blocker, either nanolol or propranolol. And you start out at a lower dose depending on the patient's heart rate, blood pressure, and the energy level. There's no maximum dose, really. You just have to titrate up until a point where the patients do not want to go off anymore because they're getting tired or the pulse is too low or the blood pressure is too low. And EGD with banding is another prophylactic methodology that we can use to prevent bleeding in varices. The other thing, too, is patients with cirrhosis, as I mentioned, 20,000 a year die from liver cancer, and most of these are arising in the background of cirrhosis. So we have to think of a way to screen, look for liver cancer before it becomes non-treatable. So this is straight from the guideline. So the whole point of us doing screening for liver cancer is because we want to catch it when it's still early in the curative phase, not when we have to use palliative treatment. So basically, we want to catch it when the patient's still a surgical candidate or they're still a candidate for liver transplant. Because when the tumor gets big or when they have multiple tumors, they're no longer in this category. And then we're moving into the palliative treatments, which is what we want to avoid. So there are several modalities that we can use to look for liver cancer. Ultrasound, cheapest, abundantly available. Most centers have this. But you look at this. Sensitivity is only 60%. Actually, most of the imaging modality that we have, sensitivity is actually not that great. Okay? Specificity is really high, but it's not great sensitivity. But that's all we have, so we're still using that. CT scan, triphasic CT specifically, not just a random CT with contrast. And a lot of time when you see on an ultrasound with a liver lesion, you use either CT or MRI to look for to evaluate for the mass. Most of the time these days, you don't even need to biopsy a liver mass anymore. I mean, if you suspected HCC, the imaging study showed it, you have a background of liver cirrhosis, AFP is elevated, you don't need to have a biopsy to prove this is liver cancer. And basically, it's triphasic. You have the unenhanced phase. Oh, what happened? You go back. Okay. So basically, this is unenhanced phase. There's a little nodule right here. When you go to arterial phase, you can see the mass much better. And this is the venous phase when the contrast is being washed out. So the problem with CT scan is a lot of radiation. And the recommendation for liver cancer screening or surveillance is every 6 months. So every 6 months with a triphasic CT scan is going to be a lot of radiation for these patients. So another option is MRI. The problem with the MRI is that people with pacemaker or patients with kidney disease, they can't really get MRI. And the specificity and sensitivity is very similar to a CT scan. So most of us, I mean, correct me if I'm wrong, but I think most of us just use ultrasound as the first line. And if that's, I mean, because it's non-invasive, it's very safe for the patient. If the ultrasound show a lesion, then you can move on with a CT or an MRI, depending on the availability of the center. Compared to the CT scan, it's very similar. It's T2 weighted with a fluid, and with the rim enhancement here, that's a liver mass. This is T1, where you can have a little fatty inside, along with the fatty liver outside here. So that's liver cancer screening. For ascites, which is one of the most common complaints that most of the patients with cirrhosis have. And basically what it is, just accumulation of fluid inside the abdominal cavity. And it can be very bothersome to the patient. It can cause a lot of bloating. It can cause a lot of discomfort. Usually patients with ascites alone should not have pain. When they have pain inside the abdomen, think of spontaneous bacterial peritonitis. And the treatment for this, I'm missing a line here, but it's sodium restriction. Most importantly, it's very difficult to control. I mean, salt intake is just such a huge thing in these population. And to make them just go straight to salt restriction, 1,500 milligram a day, is almost unrealistic. So a lot of time, most of us use a combination of diuretics, aldactone, and Lasix together, along with sodium restriction to help with the acidic fluid control. And the maximum dose for aldactone is actually 400 milligram, and Lasix is 160 milligram. So very high dose. And neither one of them should be used alone. Because aldactone, if you use alone, you go into a risk of hyperkalemia. That's why when you use Lasix, it just help with getting rid of the potassium buildup in the body. And the one that's missing is paracentesis. Because we have a lot of patients that have to get frequent paracentesis from time to time. But again, when you run with paracentesis regularly, you run into a problem with hepatorenal syndrome, especially if you remove a large amount of acidic fluid at a time. And TIPS can also be used to treat refractory ascites, meaning it's not responsive to diuretics or the patient's running into the risk of hepatorenal syndrome. And only available if the MELD score is less than 19. If the MELD score is more than 19, the patient is more likely to go into liver failure. So SBP, as I was mentioning earlier, basically it's an infection of acidic fluid. And again, most of these people, they don't have pain. When they start having pain, fever, or most of the time they present with automental status. So anyone with cirrhosis, with ascites, coming to the hospital with automental status, of course, the first thing to think of is intoxication, benzodiazepine or narcotic use. But also keep in mind, automental status from these patients can come from SBP. So always have to rule out SBP in these patients. And basically what the definition of SBP is whether you have a positive culture in the fluid or you have 250 cells, 250 PMN per cc of fluid removed. And the treatment is in the hospital. You need third-generation cephalosporins, such as ceftriaxone or cefotaxime, or albumin, and also albumin infusion on day 1 and day 3. Nothing on day 2. And if the patient has penicillin allergy, cannot take ceftriaxone, you can always use Levaquin as the second alternative. And what about when you have SBP? The chance of you have another episode of SBP is pretty high. So that's the guideline that you have to follow when acidic protein is less than 1 gram per deciliter, or if the patient comes in with a variceal bleed, or if the patient has a prior history of SBP, you might want to consider putting on long-term prophylactic antibiotics. And the one that we we don't have norphalexins in this country, but this is where most of the Europeans are using. We use Cipro, 500 milligram once a day, every day. And in the past, it used to be just Monday through Friday, and they skip Saturday and Sunday. But now it's pretty much every day. It's one of the new recommendations, and most of the liver transplant centers are using. So hepatorenal syndrome, as mentioned before, is basically your kidneys are functioning normal. And it has to be in the setting of a patient with cirrhosis or someone with severe alcoholic hepatitis that go into acute liver failure. So the kidneys itself are fine, and these patients, basically what they have is they have arterial vasodilatation and splenic circulation due to the portal hypertension. And these patients don't have normal kidneys, so if they have a liver transplant, theoretically, the kidneys will come back. But in a lot of transplant centers, what they've noticed is that when the patient have developed hepatorenal syndrome, and they live along for so long, 6 months to a year, the kidneys will fail also. Okay? And most of the time when they start doing liver transplant in these patients, after a year, they usually list it for both a liver and kidney transplant at the same time. And the diagnosis of hepatorenal syndrome, obviously, we have to rule out all the other possible causes like dehydration, infection, or intrinsic kidney disease. So typically, the UA for hepatorenal syndrome is normal, and it shows really low sodium content. Basically, it's more like a pre-renal state. And these patients, you have to demonstrate that they're not responding to fluid, IV fluid resuscitation. And the definition is basically 1.5 liters of IV fluid bolus, and the creatinine is not improving. It's just an illustration where you have high blood pressure, the high in the portal veins is backed up into the splenic circulation, and that just activates the RAS, increased water retention as well as sodium retention, worsening ascites, and eventually the kidney is a pre-renal state for so long, they start going to renal failure. So the treatment for hepatorenal syndrome, first of all, is to treat the underlying issue. So if the patient's coming in with acute alcoholic liver, hepatitis, obviously stop alcohol. And steroid, pentoxifylline, those medications can help with that. And obviously, the most important thing is liver transplant. Once you have hepatorenal syndrome, your mortality rate is very high, more than 9%. And without liver transplant, they're not going to survive. You can use auto medication, methadone, octreotide. Telepressin is basically a vasopressin analog. It's very similar. And it's not available in the US, mostly in the European country. And all these dialysis, all these are temporary measures. The ultimate treatment is still a liver transplant. So hepatic encephalopathy, which we see a lot, and the key to this is reversible. These patients don't have encephalopathy all the time. They basically is a wax and wanes condition in association with patient with liver failure or someone with a portal systemic shunt. And most of the time, these people do not have any imaging studies as positive. Obviously, you have to rule out stroke and any other abnormality in the brain. And also, they typically have an elevated ammonia level. So there are 4 grades of hepatic encephalopathy. This is difficult to figure out because patients they look really normal. And one of the first things when people start having hepatic encephalopathy is actually sleep disturbance. And that's usually one of the main complaints when they first come and see you in the clinic. When you go to grade 2, you become a little bit confused. Grade 3, when you become very sleepy but still arousable. And of course, stage 4 is when you're comatose. Hepatic encephalopathy can be precipitated by many things. So just think about it. It's a reversible condition. So first thing to do is always work up why they're in this condition. So always look for GI bleed. This is going to be very obvious, so we don't have to worry about that. Infection, such as SBP in patient with cirrhosis. Metabolic disturbance, check glucose, electrolytes. Any of these can also flip them over. Renal failure, sedatives, as I mentioned, benzodiazepine, narcotics, any of those, drug use, alcohol. Constipation can also cause worsening hepatic encephalopathy. So the treatment is basically treat the underlying problem. They have an infection, treat it. If they are dehydrated, give them IV fluid, and minimize the amount of benzo and narcotics. Again, this is easier said than done, because a lot of these patients, they have chronic pain issue. It's going to be tough. And lactulose is one of the mainstream that we use to treat for, it's actually the first line that we use for hepatic encephalopathy. And the way it works is basically the bacteria in your gut keep the ammonium form, which is NH4. Basically, it's break down lactulose and cause an acidic environment inside the gut. So the ammonium is NH4 is trapped in this form and being excreted in the stool, because ammonia is readily reabsorbed into our system. So when it's trapped in the ammonium form, it's got excreted out in the stool. Rifaximin is also being used for, actually there are a couple of studies on refractory hepatic encephalopathy. And usually it's not the first line, but if patients have more than one episode of hospitalization for hepatic encephalopathy, cost effectively, I think it's reasonable to use rifaximin in conjunction with lactulose. When I was preparing the talk, I did have a good reason to put the slide on, but now I totally forgot. A few other rare cases of complication. I'm just going to run by really quickly. Hepatic hydrothorax basically is increasing pleural effusion in the background of some patient with cirrhosis. And they typically don't have any cardiac or pulmonary issues. And they have, most of the time, they have a defect in the diaphragms, allowing fluid, instead of being formed in the ascites, in the abdominal cavity, it go into the lungs. And the treatment for this is the same thing as treatment for ascites, diuretics, sodium restriction. You can do thoracentesis as needed, and TIPS if they're not responsive. Just basically the same treatment as ascites. And I've seen several cases where chest tube was placed, and they place a Pleurex catheter used in malignant in cases of like lung cancer or some other cancer that build up pleural effusion as a way to drain this fluid. And this is a bad idea, because when you put a chest tube into these pleural effusion, you create a channel where all the fluid build up in your ascites. It's going to continue going up to your lungs. It's a vicious cycle. You can never put this chest tube out. And people go into massive protein loss, electrolyte disturbance. They can die from this. So no chest tube. Hepatopulmonary syndrome basically is a triad where patients are very hypoxic, and it's in the background of liver disease, again, with increased AA gradient. And also, they have some evidence of dilated pulmonary blood vessel. But when you do a right heart cath or echocardiogram, they don't have any increased pressure inside their pulmonary vasculature. That's no real effective treatment. Obviously, oxygen supplementation, and of course, liver transplant is the main treatment. Portal pulmonary hypertension is another cousin. But with this, you actually have portal hypertension associated with pulmonary hypertension. The pressure in the pulmonary arteries is high. And these patients can have fatigue, chest pain, dyspnea on exertion, and sometimes even syncope. And the diagnosis is echocardiogram to measure for the pressure, and also a right heart cath. The treatment for portal pulmonary hypertension is a lot of centers, basically Viagra. Okay, you decrease it's an endothelin receptor antagonist, just decrease the blood pressure in the pulmonary vasculature, and also liver transplant. However, the caveat for this is liver transplant in mild to moderate cases. When you get to severe pulmonary hypertension, then a lot of transplant center would not even offer a liver transplant, because the mortality perioperatively is way too high. It's actually up in 70%. Portal vein thrombosis, basically it's due to, because most people think cirrhosis as people are more likely to bleed, but in contrary, it's the the clotting factor is missing, but the coagulant is also missing at the same time. So it's very unpredictable whether the patient is going to bleed or they're going to clot. And when you have a high blood pressure in the portal vein, you're going to have slow portal flow, and that's more likely to increase. When you have stasis, it's where clotting more likely to occur. And treatment is anticoagulation, but this is debatable. There's only one good study that came out just a few years ago that actually supporting anticoagulation in the population of cirrhosis. And you have to balance the risk of GI bleed, especially if patients have varices and portal hypertensive gastropathy that's chronically bleeding and anemic from that. And other general management in cirrhosis, do not forget about hepatitis A and B vaccination. These patients are cirrhotic. They don't have much liver reserve to begin with. And if they get super infected with hepatitis A and B, they're not gonna do well. And of course, usual annual influenza vaccine, pneumococcal vaccine every 5 years. Patients drinking, they need to stay abstinent from alcohol. Avoid medication that can cause liver problem. And I'm not putting acetaminophen on there. Actually, NSAIDs seem to cause more problem in the patients in the population with cirrhosis more than acetaminophen. And some other supplement, herbal, the list go on and on for this, so I'm not going to list any of that. And of course, you need to adjust whenever you're on medication, look how the medication is clear. Is it renally clear or clear by the liver, and adjust the dose accordingly. So prognosis for patients with cirrhosis, when you're compensated, meaning you don't have any of the major complications that I was mentioning earlier, then the mean survival is about 12 years. And by the way, patients with varices but never have an episode of bleeding, that's considered to be compensated cirrhosis. But when the patient have one of the major complications, variceal bleed, hepatic encephalopathy, ascites, they consider to be decompensated. And the mean survival is less than 6 months when the Mayo score is greater than 21, when the score is greater than 21. And they would not survive long without a liver transplant. So when to referral when they have decompensated cirrhosis? Typically, when patients have a Mayo score of more than 10, then they should be considering referring to a specialist, do all the workup, routine workup, make sure they don't have anything that can be treatable. And when they get to maybe 14, 15 is when the patient should be referring to a transplant center. Basically get their foot in the door, basically. And of course, patient with treatable causes of cirrhosis, such as hepatitis B, C, autoimmune hepatitis, PBC, PSC. As Dr. Escobar mentioned earlier, hepatitis C is so rarely treatable now. And there's no reason to not treat hepatitis C if it's the right genotype, that is, these days. And I'm pretty sure within the next 5, 10 years, we're going to get rid of hepatitis C in general. And of course, these patients with cirrhosis are very complicated, and they can crash at any time. So they can get sick very quickly is what I'm trying to say. So there has to be a tight collaboration between the primary care providers and also the GI specialists, because again, it's a complicated issue. Okay? I think that's all I have for you guys. Any questions?